I'd like to welcome everyone tonight and give you just a little bit of context. This evening was, I believe, Cindy Pfalzer's brainchild from the very beginning. She had wanted to share some information about some post-professional opportunities in oncology rehabilitation, specifically related to board certification. And Chris Wilson is on tonight as well to speak to residency opportunities in oncology rehabilitation. And I added my name, and sorry guys, I'm going first because I just have a couple of slides because I wanted to make you all aware also of an opportunity at Oakland University to participate in a post-professional opportunity there as well. So I'm delighted to have both Chris Wilson and Cindy Pfalzer with us tonight. Certainly leaders nationwide, and we are very, very lucky to have the two of them within our state of Michigan as well. Although Cindy, I'm not sure you're spending much time in Michigan anymore, are you?
Yeah, I do.
Yeah.
I just try to escape a little bit in January and February.
Okay. Okay. So theoretically, we're all here in Michigan, which is fabulous. So I'm going to kick it off with just some brief information about the graduate certificate in oncology rehabilitation at Oakland University. So it is here in the state of Michigan. However, it is all online. So we have students that are literally participating from around the globe, from Israel, from Iran, from Saudi Arabia. We have lots of students in the United States as well, but it's very, very diverse and a wonderfully global population of students. So that is one significant strength of the program. It's interdisciplinary. We have just in the last 2 years started accepting students who are occupational therapists or speech therapists. We also have, there's a little typo there, PTA and OTAs if they have a bachelor's degree. And starting this fall, we will also be matriculating students in exercise science if they have a master's degree. So as mentioned, it's an online program. It is 17 credits. And those of you that logged on earlier, I mentioned that we have a Google Drive. You'll be able to download this slide deck once we upload it. And then there's also additional resources which will provide you information on what those 17 credits entail. So it's a good preparation for board certification, which we will be speaking to shortly. Helps to develop advanced skill in prevention and management of oncology-related impairments. And then this is our systems quadrant approach to the curriculum. Speaking to musculoskeletal, metabolic, fascial, cardiopulmonary, immune, gastrointestinal, neuromuscular, vascular, integumentary, as well as the reproductive system. So you get a very good systems approach to oncology management. There's also an additional elective in pediatrics, if that is an interest of yours. And throughout the curriculum, you get administrative or program development support. So if you work for a health system or perhaps a chain of clinics that doesn't have a very robust program, we have some support for you in that domain as well to help develop the strength of the program, providing strategies for marketing and those sorts of things as well. So the link is here for additional information. That's the website. And as I mentioned, there is a 2-page PDF that will also be included on the Google Drive that you can download for additional information. I have Dr. Deb Doherty's email address here as well as mine. If you have questions and would like to speak one-on-one, we do those one-on-one sort of Zoom calls very often to answer questions on a one-on-one basis. All right.
So Cindy and I have done this roadshow for quite a few years at the national level, kind of when we started residency and specialization. Cindy, do you want me to go first or do you want to go first? Do you have a preference?
Chris, if you don't care, I'll go ahead and go first, and I'll try to actually fly through these slides because people can download them. And I do want to say that the links in the PowerPoint are active. So you should be able to get to a lot of ABPTS and that's the American Board of Physical Therapy Specialization. And also, I know Chris will probably reference, and I did include some resources here from the American Board for Physical Therapy Residency and Fellowship Education. All right, you can go to the next slide. Oh, if you go back for a sec, I'm sorry, I should have mentioned something. The ABPTS link here, if you click on that brown ABPTS, that'll take you to their homepage. So that's an active link, guys. And on to the next slide. So what I hope to cover tonight, along with Chris, is to talk about the specialty council that oversees clinical specialization in oncology, talk a little bit more about how ABPTS is organized, just so you have a general sense of what's going on at the national organization that oversees the process. And then to talk about the clinical specialization in oncologic PT specifically, and the two different pathways to get to specialization, one of which is residency. And then to identify a lot of the resources and processes available to help you apply for the exam and study for the exam. And then talk a little bit about the exam format and the components of the DSP, which is the description of specialty practice. And there is a mirror document for residency called the description of residency education. Then a little bit about the what we use a lot of acronyms, as you can tell. And SACE stands for the Specialization Academy for Content Experts. They are the people who actually write the items for the exam. And for those of you who may be clinical specialists who are on tonight, or who are thinking of becoming clinical specialists, this is one of the ways that you can serve after becoming a clinical specialist. All right, next slide. All right. So for oncology, and there are some real roots in Michigan related to clinical specialization. Back in 75 and 76, when there was a task force on clinical specialization, Dick Darnell, who was the program director at the University of Michigan's program, was one of the people on that task force. And of course, the first clinical specialization after the House of Delegates adopted clinical specialization was cardiopulmonary. And for oncology, I think it's on the next slide. If you go ahead, yeah. The House of Delegates approved oncology in 2016, and the first exam was offered in 2018. And there are 10 specialty areas and 9 academies that oversee those specialty areas. It turns out that clinical electrophysiology and wound care, which is the most recent one approved by the House of Delegates in 2019, are both overseen by the Clinical Electrophys and Wound Care Academy. Everyone else is in a single academy. All right, number of specialists. And I don't have the most recent data in here, but it is pretty much flattened out during COVID. But as you can tell, orthopedics pretty much dwarfs the other 9 specializations. But certainly Jerry, neuro, sports, and pediatrics are not far behind. Next slide. And this kind of shows where things have started to flatten out in the last couple of years, but there has been a massive growth in the number of clinical specialists, especially in the last 20 years, as you can see by the graph. Next slide. All right, a bunch of links that are resources for those of you who want to think about starting a program are available. I think the same thing is true with residency. There are links for both participants, people who are going to undergo residency, people who are looking at taking the clinical specialization exam, and then those that are looking at developing programs. So you'll see both links there when you get to the home pages for both areas. And certainly, I think as an individual, if you're thinking about clinical specialization, you should take a look at the PowerPoint on enhancing professional development through certification, along with all the nuts and bolts of how the exam's developed, constructed, and scored, and certainly what the minimum eligibility requirements are, which tend to be somewhat standardized, with the addition for 4 of the academies requiring, besides the minimum eligibility requirements for the academies, or actually 3 of the academies, including wound care and clinical specialization. So 4 have a requirement for case reports: oncology, cardiopulmonary, women's health, and then wound care all require a case report as part of the eligibility process for sitting for the exam. Next slide. And those are all active links, right? So you can click on those and it'll take you there. This is the current Specialty Council for Oncologic Physical Therapy. It's our job to oversee the minimum eligibility requirements and recertification based on the American Board of Physical Therapist Specialization guidelines at the national level. It's also our job to screen applicants for the exam eligibility and recertification, and then to develop the exam, along with the National Board of Medical Examiners at this point in time. Although ABPTS is going to have an RFP out to look for a new provider for the exam, as the National Board of Medical Examiners is getting away from this kind of specialization exam process. So in addition to myself as chair, the other 3 members of the Specialty Council, Jackie Druin is the item review coordinator, Amy Tibble, who's at Memorial Sloan Kettering in New York City, is the person responsible for the maintenance of clinical specialization. And then Beth DeMyers, who's down at the Moffitt Cancer Center in Tampa, Florida, is the assistant item review coordinator and member at large. Amy also oversees the review of the case reports for people to sit for the exam. Next slide. So this takes you right to the main page, this link for oncology clinical specialization. And right now there are already 105 clinical specialists who've gone through the first 2 cycles. And I'm pretty sure there is another 28 or 29 that are in the mix to add to that number. And for this coming exam cycle, the deadline tends to stay July 1st, but as of COVID with a lot of other things, deadlines have been extended. So I'll talk a little bit more about that. Farther down, I think I have all the deadlines for this year listed. Next slide. Yeah, for those of you who are clinical specialists already, if you do want to become a member of the Specialization Academy of Content Experts and contribute items to the exam, that's the link that will take you to the volunteer opportunities for people who are already clinical specialists. If you're interested in applying to become a clinical specialist, one of the first documents that you want to download is the candidate guide that walks you through the application requirements and process. And of course, the application is online. We always need reviewers for case reflection also. So if you're, again, a clinical specialist and you don't really want to write items for the exam, another volunteer opportunity you have is to be one of the case reflection reviewers. And if you're interested in that, you want to contact Amy Tibble. If you're interested in becoming an item writer, you want to contact Jackie Druin. And you might not have noticed because I flew by it pretty quickly, but on the slide where the Specialty Council for Oncology is, their emails are all there also. Next slide. So one of the things that sometimes people confuse is where specialization sits in the academy. So for the academy oversees resources, answers questions, provides information. But truly, the Specialty Council reports to ABPTS. And so we don't report to the academy. And sometimes people get a little confused about that. But certainly, I sit at board meetings with the academy, and we do a lot of communication back and forth to try to make sure that we assist any members that are interested in specialization. So even though we're separate entities, we do collaborate a lot. If you have questions, certainly you can email me. Nicole is no longer the council chair. I am. At this point, Amy Tibble will be the council chair next year. And then information relative to specialization on the academy site, the link is listed here, and I'll talk a little bit more about that down the road with some other resources shown and links to those. Next slide. So how do you get there? Again, we do this kind of Q&A at CSM every year as part of the program for the academy. By mid-May, you really want to start working on your online application because the deadline it's actually been extended again this year. So you want to go on, it's not July 31st. You can go on the web and check to see how far back they're going to move that deadline. I am not sure they're going to open it up as late as they did last year, which was October. They're still in discussion about how long they're going to leave the application open. And certainly you want to make sure that you start studying for that well in advance of the exam. This is not an exam that you can cram for. And then there are two different deadlines related to fees that always do hit in November. One is the initial certification for the exam deadline. And then there's a fee later on to actually sit. And the exam is always offered in late February to early March. And I know I have those timelines updated on another slide. So go ahead, next slide. The minimum requirements, again, can be pulled from this PDF off the link, but you have to be from one of the US states or a territory, or obviously the District of Columbia or Puerto Rico. You have to have 2,000 hours of direct patient care in the last 10 years, with 500 of those hours having occurred in the last 3 years. And this issue of what is direct patient care always gets a fair amount of discussion and questions. So I'll deal with that in a little more detail. Next slide. So in addition to the minimum requirements, the hours with direct patient care, and the case reflection, there are a couple other options here. And so self-study is really the option A, and option B is the residency. So let's talk about each one of those in a little more detail. Next slide. Again, just a repeat of the minimum requirements, so you have them all on one slide. Those 2,000 hours over 10 years, 25% or 500 hours in the last 3 years, the reflective case report. If you're a graduate of a residency program, all right, I'll talk about that in a little more detail after the case reflection. So hold that thought. The purpose of the case reflection is to demonstrate advanced clinical reasoning and decision-making that is reflective of an oncologic clinical specialist. And this relates to clinical specialists having the ability to synthesize information from a variety of sources, including but not limited to the patient-client management model, which includes screening, examination, differential diagnosis, intervention, and incorporation of the literature or evidence-based practice. Clinical specialists are able to incorporate what is learned from each patient case, positive or negative, into future patient management. And the case reflection is to demonstrate learning experiences by providing rationale for decision-making throughout the plan of care. And then again, relevant citations to the literature should be included in the case reflection to demonstrate that evidence-based practice. Next slide. So, residency. If you're a graduate of a residency program, the only thing that you have to provide is a letter from your program director and then your case report in order to sit for the exam. All right. So the minimum requirements here are basically waived if you have a letter from your director saying that you're soon to complete a residency program or have already completed a residency program, and then submit your case report. All right, so here are some of the links for residency. I'm sure Chris will elaborate on these. I just put them in here because you do have both options in order to become a board certified clinical specialist, the self-study option or the residency pathway. Let me just say something about success on the exam that's related to both these options. There's no doubt, given the data at the national level, guys, that the graduates of residency programs outperform people who self-study. That doesn't mean you shouldn't self-study. It's certainly a viable option, but there's good data that demonstrates that graduates of residency programs do outperform people who self-study. So for the people who are going to self-study for this exam, I would really encourage you to form study groups, get very familiar with the literature. This is a tough area to get your head around, a lot of that literature, and there's an immense amount of literature available. So just kind of keep a few of those things in mind as you think about self-study. And again, the Academy has some resources to help with the self-study. I think there's about a 32-page resource document out there from 2017 that, yes, we know we need to update, because the literature has changed in that 3 years. But certainly up until that point, it's a great resource document. All right, next slide. The other thing I would probably say here relative to the case reflection, most residency programs do require a case report as part of the residency curriculum. So I don't think that's really an additional requirement. It's just a matter of doing the submission of something that's probably required in your residency program already. So don't think of that as additional work. You've already done the work. You just need to submit it. All right, next slide. There is a SIG, obviously, for residency in the academy. Sean Mosley at Memorial Sloan Kettering is the current SIG chair. Chris is, I'm pretty sure, a past SIG chair. So he can certainly speak with authority on this topic, and for a variety of reasons, including having established the first accredited residency program in the country. So what is provided by the American Board for Physical Therapy Residency and Fellowship Education, again, are a bunch of resources for both people interested in developing programs and for participants. So you do definitely want to go there and check out a lot of those resources. And the SIG has some resources up there in addition to the listserv, where you can exchange and communicate with other people involved in both residency education and people who are residents in residency education. And the primary document that's the description of residency practice that I mentioned earlier is also available from that same website. All right, next slide. The current residencies that are accredited or close to accredited. All right, the first 5 here are already accredited. And then I know that James has their accreditation visit coming up in about 10 days. Because one of the things I do in my other life and volunteer experience here is I'm one of the site visitors for residency accreditation programs. I either sit there as the content expert or the team leader on these accreditation visits, except for, in fact, Beaumont's, because it's a conflict of interest, right? It's a little too close. So even though I spent 5 years down there at the Cancer Center at Ohio State, that was more than 30 years ago. So I think we're clean. Next slide. All right. For specialization, then, this is just the link, again, to where the application is. And I just mentioned here that every year it opens right about the middle of May. So that hasn't really changed. And that July deadline, while I mentioned it was extended for COVID and is probably going to be extended this year also, it won't be July. I'm not sure when that deadline actually will hit, but it'll certainly be after July 1st. Again, the candidate guide, just to give you a little more detail, describes the application process, and is really critical that you really read that from front to back to make sure that your online application is complete. And you do want to allow at least 6 weeks for the application review. Again, with COVID, it's taken a little bit longer than that for the staff to do their initial review at ABPTS before they ship it to the specialty council for review. All right, next slide. So the link again are here. Just go ahead, get on there. And certainly, if you have additional questions that come up, you can certainly email me. I'm happy to answer them, but you can also email the folks at ABPTS. All righty, next slide. See, I did put up the deadlines. So these are the ones that are corrected supposedly for this year, but we've already been told they're being extended. So just so you know, I doubt that they'll probably extend the fee deadline, but as far as the application deadline and reapplication deadline, I know those have already been extended, but the test dates are set. So it is from February 26th to March 12th for the 2022 exam. All right, next slide. And the fees structure has not changed from last year. They've kept the fees exactly the same. So if you get on there and take a look on the ABPTS page and you get into the application site, you'll see the member and non-member fees link there. And the total for members between both the application review fee and exam fee is a little bit in the $1,335 range, and for the non-members, $2,405. And again, board certification is for 10 years. I'll talk a little bit about maintenance if people have questions at the end, but otherwise I'm just going to talk about initial certification. All right, next slide. So the description of specialty practice is available for a fee, but if you apply to take the exam, you in fact get a free copy of the DSP along with the self-assessment tool that goes hand in hand with the description of specialty practice. So both of those come if you actually apply to take the exam. But again, they don't come until you apply. So if you want to get a head start, you actually have to pay for the description of specialty practice. There are a couple chapters, however, chapter 2 and chapter 4, which are available online for download free of charge. And I actually do include them in the slide deck farther on. Next slide. This just shows what the DSPs look like, including oncology and the other 8 that were available at the time. Wound care hasn't put their DSP out yet. I mentioned that the description of specialty practice outlines the content for the exam. Specifically in chapter 4 is the outline of the exam, and in chapter 2 is the long list of potential diagnoses, impairments, symptoms that can be covered on the exam. The exam's approximately 200 questions. Sometimes it's a little more than that when they're trying to check the reliability of items, but it really is a minimum of 200. The questions can include graphics, pictures, or even video clips, and they are to represent the best practice expectation and knowledge area associated with oncologic physical therapy. So what are the 200 most important things for you to know about if you're an oncologic physical therapist? All right, next slide. So more links for you. Again, the link to the description of specialty practice will take you to a site where you can purchase. The outline, which is chapter 4, is there free of charge. What activities constitute direct patient care is a separate document that I think you do want to download and take a close look at. And then there are some exam prep materials there and an exam tutorial to kind of get used to the format of the exam. And the format is such that there are multiple choice questions where there is a single best answer, but there can be more than one correct answer. It's the best answer. And there's no like combinations. There's not like A and B, all of the above, none of the above, all that stuff. There's a clinical scenario or a STEM, and then you have 4 answer options, A, B, C, and D to choose from. Next slide. These are the resources that you can find on the Academy webpage that link to specialization. I mentioned the resource guide for specialization. There's also an EDGE annotated bibliography, and all of the EDGE manuscripts, which are systematic reviews on different outcome measure domains in oncology, are in the Rehabilitation Oncology Journal. And they are, most of them, I do believe, are free of charge. So the Rehab Oncology Journal is an excellent resource when you're looking to look at the systematic reviews on outcome measures, which the EDGE reviews are. In addition, OncoReads is an opportunity for CEUs that's attached to the journal. And these are 5 or 6 articles a year pulled from the journal that you can go to the APTA Learning Center for a very reasonable cost. Read the article, complete the, I think it's about 15, might be 10 multiple choice questions. Get your CEUs and get a nice opportunity to actually study for specialization. And there has been some method to the madness in the Rehab Oncology Journal. There's a special issue each January, and some of you jumped on and heard me talking about the Balance and Follow special issue that just came out this January. But previous special issues have included pediatric oncology, lymphedema, hospice and palliative care, some areas that people who work, for example, maybe at a cancer center may not feel as comfortable with, or people who work in outpatient clinics may not feel as comfortable with. So there was some intent in putting those special issues together to actually help with clinical specialization in oncology. Next slide. I mentioned the Specialization Academy of Content Experts already. These are 2-year terms. Typically, we ask you to write a minimum of 5 to 6 items. To qualify for the incentives that ABPT offers, however, you need to complete 10 items, just so you know. Those incentives are quite nice. But that's kind of the minimum requirement that we're asking. The application portal actually is open right now, usually stays open to the end of April. This year, I think they're leaving it open until the end of May. Next slide. So, because this was a relatively new specialization, there was no embargo in place if you were a member of SACE, but an embargo goes into place this year. They gave us 5 years to not have an embargo in place. What that means, if you're a member of SACE, you can't actually sit and take the specialization exam. And the specialty council's embargoed for 5 years, by the way. We're not even supposed to teach anything relative to continuing education that could relate to the exam. And that's to try to keep the exam as secure and clean as possible. But certainly from the Specialization Academy, there's an opportunity to become a member of the Committee of Content Experts or to actually sit on the Specialty Council. I think that's all I'll say about that. You can always talk to Jackie, Beth, or I if you're interested in that opportunity. All right, the nitty-gritty of the exam. Next slide. The objectives for the exam are to demonstrate competence as an advanced practitioner in physical therapist specialty area. So that is beyond entry level, but that is not expert. That is what we mean by advanced practitioner, right? It's to formally recognize those physical therapists who obtained advanced knowledge and skills in the specialty areas, and to assist the public and healthcare community in identifying therapists with acknowledged expertise in a particular field, in this case, oncologic physical therapy. Next slide. So I've already mentioned a little bit about how it's developed with the Specialty Council, the Committee of Content Experts, and then the Specialization Academy of Content Experts in collaboration with the National Board of Medical Examiners, and ABPTS oversees the entire process. It is a criterion referenced exam. Everything has to be based on the literature. And it is administered once yearly for that 2-week period. And you saw that again coming up in 2022. It's at the tail end of February and beginning of March. It is computerized. Prometric test centers worldwide are where it is currently administered. And the multiple choice questions I talked about a little bit already, with case scenarios, graphics, pictures, videos, etc. It is 7 hours available to complete the exam. It's administered in 4 blocks that are 1.5-hour long sections, where you have up to 50 minutes for a break after any of the sections and time for lunch. And one of the important things to know is once you complete a section, you cannot go back into it. It's done. You move on to the next section. Okay, so there's no going back later in the exam. You complete each section and each section stands alone. And that's a long 7 hours. There's a link to Prometric. The exam dates for 2022 I've already given you. And then here is the number that you can call, the 800 number, if you want additional information and you don't want to email ABPTS. All right, next slide. So this is chapter 4 of the DSP that's available free of charge. You can download it right off the link here. The knowledge areas are 15% of the exam, and that breaks out into 5% for foundational sciences, 5% for clinical sciences, and 5% for behavioral sciences. Next slide. Then in the professional roles, responsibilities, and values, total 16% of the exam, and A through J are essentially 2 to 1% each. And that includes professional behavior, professional development, communication, social responsibility, leadership, education, advocacy, administration, consultation, and evidence-based practice or research. Next slide. And then the bulk of the exam, 69% of the exam, comes from the patient-client management expectations. And again, those include examination, re-examination, evaluation, diagnosis, prognosis, intervention, and instruction, and outcomes assessment. So that's 100% of the exam total. Next slide. All right, this is chapter 2 out of the DSP that lists the different medical conditions, types of cancer that are covered on the exam. And I'm not going to read every type of cancer here, but pretty much A to Z. And then a couple of things linked to some oncological emergencies like perineoplastic syndromes. Go on to the next slide. Also, it's laid out by system here, so you'll see some impairments and symptoms linked to the musculoskeletal system and things specific to cancer, like bone metastases, weakness, pelvic pain, vaginal fibrosis, hormonal deprivation, induced osteoporosis, for example, from things like androgen deprivation, therapy used to treat prostate cancer, loss of range of motion, often due to surgery, nerve injury, scarring, etc., like cording, axillary web syndrome, neurological complications and impairments, known side effects, things like chemo-induced peripheral neuropathies, balance dysfunctions, lumbosacral plexopathies, brachial plexopathies, nerve palsies, like spinal accessory nerve impairment seen in head and neck surgeries, gait abnormalities, spinal cord compression, again, another oncologic emergencies, things where you might see increased intracranial pressure with brain or CNS metastases. Next slide. Changes in the integumentary, like radiation fibrosis, radiation toxicity, skin extrusions, infections like cellulitis, cardiovascular and pulmonary complications, everything from deconditioning to cancer-related fatigue to lymphedema to cardiac induced toxicities from chemotherapy or radiation, interstitial pulmonary fibrosis, cachexia, and another oncologic emergency, vena cava syndrome, pulmonary metastases, immunosuppressive effects, fairly well known, including complications these days from even CAR-Ts, which were just added to the exam. And then end of life issues. All right, next slide. So in chapter 2 of the DSP, each one of those areas on the exam is blown out in more detail. So I just put up here the blowout for the clinical sciences part under the foundational sciences. So you could see an example of some of the things in more detail and why you might want to look at that DSP in more detail. So when you look at the clinical sciences and the expanded content, you're looking at things like pharmacology, kinesiology, pathokinesiology, exercise physiology, the taxonomy of cancer rehab principles, like prevention, restoration, supportive care, and palliative care, cancer tumor staging, tumor pathology, genetics and genomics, cancer control science and epidemiology, so prevention, screening, risk factor identification, surgical oncology, like reconstructive surgeries, along with primary surgeries for tumor resection, medical oncology, such as the chemotherapy side effects, hormonal agents, biological agents, targeted agents, of course, radiation oncology, laboratory tests and measures, diagnostic imaging, the list goes on and on. I know. All right, next slide. All right, so instead of doing regional workshops for item writing that we used to do to help people understand the exam and understand what it would take to be an item writer, we've had to switch over to virtual item writing workshops due to COVID. And the next two coming up, there's one June 5th and there's another one September 25th this year. And you would contact Jackie Gruen if you're interested in participating in those. These workshops are a great way to get a better understanding of item writing and how the exam is constructed. And I'll leave it at that. These, of course, are done through Zoom. All right, Chris, you're on. Take it away.
Thanks, Cindy. So I'm going to talk to you guys about kind of the residency end of things a little bit more detail. So Lori's going to kind of flip back to the residency slides. But even if you're not interested in potentially being a resident yourself, certainly you're going to be an oncology mentor and kind of, you know, you're probably going to be getting some questions from some students who might be interested in potentially attending an oncology residency and know a little bit about it. So my name is Chris Wilson. I'm actually the vice president of the Oncology Academy right now. I'm also the residency program director, and he was on just a little bit ago. Andrew Chongaway is our senior therapist in charge of oncology, and he's a graduate of Beaumont's oncology residency. So next slide. And some of these slides, Cindy went over them a little bit, so we're going to kind of probably skim through them. So just like the ABPTS, there is a accrediting body for residency and fellowships. It's a word salad of an acronym, ABPTRFE, so it does not roll off the tongue. If someone is interested in applying for a residency program, most programs use what they call RFPTCAS. And if you've applied for PT school in the past few years, you probably utilized PTCAS. Or if you're a mentor, you probably filled out some letters of recommendation through PTCAS. They have the same thing for residencies called RFPTCAS. And the one that I'm going to be talking about, the only one in Michigan right now, is Beaumont's oncology residency. I'm not aware of any other ones that are starting up in Michigan, but certainly a lot of this stuff applies to several of the residencies. So next slide. So hopefully by the time you're done, you'll be able to identify the benefits of participating in a residency, talk a little bit about the application process, figure out where they are, and then kind of talk a little bit about new grad resident to specialist, as Cindy fairly well illustrated already. So next slide. So as we know, oncology is really not established well in entry-level education. You know, therapists of this level are really scarce and of high value, which is why I'm so excited you guys are on this call today, because there really is a market for these services, but really there's a lot of patients out there and there's not enough qualified therapists. So we really kind of need to train our own therapists through specialization and through residencies. Next slide. So really, what is residency education? This is really a curriculum. Basically, you're kind of almost enrolling in another year of school, but not necessarily at a university, almost always at a healthcare system. There are some, like Ohio State, that is kind of affiliated with their academic medical center. Very similarly to specialization, there's lots of accredited programs, some areas that don't necessarily have a specialty examination like acute care. You can't be a board certified acute care specialist, but there are residencies for acute care. But in oncology, there is a residency and there's specialization. So the rise of residency education, you can kind of see that it matches up very well with the number of specialists that we have. So really both of them are growing quite substantially. You can see that there's a lot more residencies and fellowships. And just stopping for a point for what's the difference between a fellowship and a residency, really the residency is kind of more foundational specialty training. So kind of oncology, for example, would be the residency training. And then if somebody wanted to be a pediatric specialist, for example, there are no pediatric fellowship for oncology yet, but that would potentially be an example of a subspecialty within a specialty. It's kind of one way to do fellowships. And with regard to oncology, there really aren't any yet. As Cindy said, these are the 6 residency programs that are enrolling residents. Other than the Ohio State University, all the rest are accredited. And as Cindy said, Ohio State's site visits coming up very soon. So really the practice settings and population are kind of something, really most residencies, it's a job. You're kind of working at a job for an extended amount of time, very similar to like you went to PT school. So it's not like the graduate certificate in oncology rehab where you can kind of keep working full-time at your own job. You're kind of getting hired in there, you get a salary, you're almost always, at least at Beaumont, a full employee with tuition benefit or tuition reimbursement and health benefits and a 403B and all of that kind of stuff that a job entails. For residencies, the description or specialty practice says there has to be experience in acute care, inpatient rehab, outpatient, and skilled nursing facility. So skilled nursing facility is one area. I see one of my residents, Brianne, is on this meeting today, and she's actually going to our Beaumont skilled nursing facility next week and the week after to get some training in that area. And then of course that's going to be covered with extra coursework and things like that. So they also have to kind of cover the health or the lifespan spectrum. So from pediatrics to adult geriatrics, and then both the male and female sex. So they have to kind of cover the depth and breadth that is oncology, and that's especially challenging for this patient population. For example, in orthopedics, you can get away with doing a whole residency just in an outpatient ortho clinic. That's not necessarily the case with oncology, because lots of our patients do go into acute care, IPR, or skilled nursing facilities. So next slide. So here's some kind of sample residence goals. This is actually from Beaumont's oncology residency, as what the resident is expected to accomplish. They're going to be proficient with evidence-based, best clinical practice, patient-centered care, applying current research. They're going to be an expert educator to patients, peers, and students. So Brianne and Scott, already my residents from this year, already went to Oakland University and did a lecture on oncology rehabilitation. And they're also kind of doing those for other institutions as well as they come up. Community service, I will admit that one has been a little bit more of a challenge because of the pandemic. It was really, really easy just to have the residents pop into some type of community event, but with the pandemic, a lot of things have gone virtual, so we have to be a little bit more creative with that. Certainly being ready to complete the specialist examination, and then meeting all of the criteria of the curriculum. Next slide. So really, what is that residency curriculum? It's defined by that specialty practice and residency practice, and a good residency will be covering both of them, because ideally it's a pathway to specialization. So it should be kind of training you to not just be a good resident, but also to sit for the exam. There's lots of educational methods. So there's written tests. There's a midterm and a final at Beaumont, and they're both proctored examinations. They also have to do live patient examinations, which is kind of like a practical examination, but with a real patient. So if you're kind of having flashbacks to PT school, it is somewhat similar to that. And there is also didactic instruction. So there is some classroom learning. So what I usually tell resident applicants is, we try and keep your on-the-job training to 40 hours a week, but just like if you were taking a night class, there's probably anywhere between 5 to 10 hours of extra reading and watching webinars and being in our journal clubs for pretty much every week. So they have to kind of understand that. So next slide. So here's some of the one for Beaumont's. Ours is actually a 12-month clinical residency. So we actually usually enroll a new cohort every October. Beaumont right now takes 2 oncology residents. We started with quite a few more of that because we wanted to kind of train our own faculty. And the best way to train our own faculty is to take them through the residency program. So they start in October and they graduate in October. So the application window is actually open at the end of this month until June. So, there's really rotations through all the different specialty settings. So as Cindy said, it's not necessarily just breast cancer and lymphedema. There's pelvic and genitourinary cancers. There's head and neck cancers. There's palliative care. So there's lots of different areas that they will go through. The other fun thing is this isn't really specified in the DSP, but I think what are kind of like the icing on the cake things are being able to do some of the interdisciplinary things. As you guys know, if you don't like working with an interdisciplinary team, oncology might not be the best for you, because you really do need to work with the oncologists and the radiation oncologists and the nurse navigators and the social workers and all of those folks. So you can see, attending Gilda's Club or health fairs, shadowing with the doctors, participating in tumor boards, and then doing multidisciplinary screenings. And of course, they get some specialty exposure, not necessarily mastery of any of these. To be a lymphedema therapist, if anyone's a lymphedema therapist, it takes a lot more training than the residency can provide for you, but it's an introduction. Next slide. So just here's some examples, some of the things that our residents have done. They attended, within radiation oncology, our proton beam center at Beaumont. Beaumont has the only proton beam center in, at least in the Midwest, I think definitely in Michigan. And they have a chance to kind of observe and actually do pediatric screens in the proton beam center. Working with our geneticist, that's the person in the center, is Dr. Dana Zakalik. She's actually the co-chair with Deb Doherty of the Michigan Cancer Consortium right now. So medical oncology, inpatient rehab, and certainly getting to look at a lot of interesting images. This is a PET scan of a patient with head and neck cancer. So this is kind of an examples of some of the things that residents kind of get exposed to through immersion. So with didactic training, it's really a hybrid educational module. There's actually 6 modules, which we'll see the next slide. Each module has a certain amount of clinical mentoring. And for Beaumont's, it's about 7 to 10 hours a week of clinical mentoring. Basically, the ABPTRFE only requires 150 hours, but we've over-engineered the program. And we were actually glad that we did last year because of the pandemic, uprooting everything. All 3 of our residents were still able to meet all of the criteria because we over-engineered the amount of mentoring and exposure. And then again, they also do that academic coursework, and they do have that final examination. And then, as Cindy said, they have to do some type of longitudinal capstone project. They don't have to do a case report, but from what you heard from Cindy, it's highly, highly, highly recommended because we can help you write the case report. We won't write it for you, but we can certainly help out with that. And Lori's been a great point person for this year's oncology residents to help them with kind of theirs as in her role as a part-time faculty at the Beaumont's residency program. So next slide. So here's some of the different modules that our residents go through. They start with the foundational stuff, general cancer concepts and cancer rehab. So kind of starting with the basics, maybe all the things that you wish your DPT program taught you but didn't. And you can take some of these in different orders because we only have a certain amount of mentors. Breast cancer and lymphedema, acute illness, lung, thoracic, and circulatory. We've kind of grouped those together because that's where we see most of that patient population is in the acute care setting. We don't see very many lung cancers in outpatient unless you're in a pulmonary rehab facility. Same thing, psychosocial aspects, palliative care and hospice. That's also an acute care and IPR rotation. Then we actually team you up with one of our pelvic floor specialists to go through GI, GU, and GYN cancers and really kind of learn some of those things. Now, you don't necessarily do a lot of, you're really doing any internal examinations, just like lymphedema. That's an advanced technique, but certainly being in the room, helping out with some of the external exercises and understanding the care philosophy. And then if you want to go through further and become an oncology pelvic floor specialist, you have a solid foundation. And as you can see, head, neck, and CNS. So next slide. So here's some of the examples of the core modules. So, they do have the didactic coursework. So what readings and videos and journal clubs, these are almost all asynchronous. And then they do have hands-on experiential knowledge. Then again, some of those observational experiences. So we kind of say you have to shadow with an oncology nurse navigator and shadow with a medical oncologist and tour the radiation oncology department. And then they have to, before they can go on to the next module, they have to pass the examination. 80% for our program is kind of the magic number. So we make it kind of easy for everyone to remember. So here's kind of a little bit of what a resident schedule looks like. So although they do work 40 hours a week, about 30 hours of a week are really just straight up seeing as many cancer patients as we can filter through to them. So they're kind of seeing about 30 hours of direct patient care. There's always a mentor on site if they have any questions or have any needs. And then there's also some one-on-one mentoring. So, again, anywhere, but usually between about 5 hours a day. So this is just kind of one sample, not 5 hours a day, but about 10 hours a week. So like Tuesdays and Thursdays would kind of be some of those times. So this is a little bit of an older schedule. It's been updated a little bit since then. This was kind of for our first cohort, but it's been a little bit expanded for the mentoring. All right, next slide. So as we said, the capstone project is some type of project. In past years, we've had some folks who've done a quality improvement project, but most recently, almost everyone's been doing the capstone project. And these are shared with Beaumont team members. We've had 5 of our students or our residents already have their capstones published, and we're working on 3 more as we speak. It usually is kind of after they graduate, and then we kind of leave them alone until after they take their board certification. And then after that, then we kind of come back even after they're gone from Beaumont to help them with their publication process. So you've kind of built a career ally for life when you've kind of done stuff like that. All right. So here's just a sample of kind of what the Moodle page is. So Moodle is kind of the way that Beaumont kind of chooses to deliver their content. If you've taken a DPT course recently, it's probably Blackboard or something like that. Very, very similar. So you can kind of access those at really any time that you want to. Next slide. We're also very lucky to have library resources. They also have, we also have kind of a librarian dedicated specifically to us to help out with lit reviews and give a library orientation to make sure that all of the residents have access to some of the academic support that they need. And they built us a really good library webpage as well. All right, next slide. Let's see. So these are just a little bit more informational slides. I don't think we're going to spend a lot of times on these few slides, but some of the different learning experiences we said, they can also take external CE courses. We always highly recommend that all of our residents attend combined sections meetings so they get time off and they get education time to attend that as well. Next slide. Here's some of the resources that they use. Right now our required textbook is the Stubblefield text. It's a very beastly text. There's a lot of information in it. And then even things like the Oncology Edge Task Force reports. As Cindy said, Rehab Oncology is really one of the best resources. And then even again, continuing education courses. If someone wants to be a lymphedema therapist, they certainly can. Then there's lots of learning experiences like labs. We always do clinical discussions, as we said, mentorship sessions. And then we almost always have the residents do some type of special project as well. So some type of quality improvement project. Last year it was building an orientation guide for all of the staff members to kind of understand the basics of oncology rehab. Next slide. So as we said, the minimum of 1,800 program hours, 300 of those have to be educational hours. So that's kind of the didactic component to it. And they have to have 1,500 patient care hours, with 150 of those hours being that one-on-one mentor, where you're just working one-on-one. Sometimes the resident's in charge, sometimes the mentor's in charge, sometimes they're kind of hopping back and forth. One of the big things to make sure that you meet the criteria for the description of residency practice is you're logging your diagnoses. So we kind of want to know, are you getting enough diagnoses? And if not, kind of always the ones that are weird are like skin cancers. We don't see a whole ton of skin cancers, but when we see one, we tell the other resident, oh, come on, go look at this as well. And if for some reason there's just not an opportunity for exposure, we are able to go through and make sure it's covered in Journal Club, or get them to a special experience where they do work with that patient population. All right. So how do you find that perfect fit? So what's really a good candidate for a resident? Really, it's that self-directed learner. It's kind of the person that wants to be there. If you're a person that kind of waits to have people tell you exactly what to do before you do it, maybe a residency program is kind of not the first choice for you. So being very flexible, curious, good communication and time management skills. I mean, it really is, you're kind of an autonomous learner, but working within the framework of the curriculum that has been built. And really, are you going to be a good ambassador for oncology PT? So, I probably imagine that everyone who's on this call is already here because you're already curious and self-directed. So I imagine you guys are probably already good candidates. So this is our first cohort on the front, our first graduating class of oncology residents, and these are all of our faculty members, or at least have been in the past. Some of them have moved on to bigger and greater opportunities. So with that, I think that is the end of my presentation. So maybe Lori can kind of go to the QR code with the presentation information. We'll probably have some time for some questions.
Perfect segue. So, yep, this code, you guys, if you scan it with your phone, it'll bring you to a Google Drive that you'll have access to downloading any of the materials that were referenced tonight. With one small caveat, there was a last minute change to this slide deck, so we will have that up later tonight. So my recommendation is not to pull that down tonight. The other resources are should be sufficient.
Great. I'm sure we've got some questions out there.
Yep, just unmute yourself and we'll do it real casual.
We're all casual and friendly in oncology. You must have done a good job, Cindy.
Oh, I'm sure. If you can't think of anything tonight, if you do have my email address and Chris's email address, but certainly I'm sure there's more questions about things like what counts as direct patient care.
Good presentation. Thank you very much. But yeah, it's a lot. I was taking notes and I'll take a look at it after too. Thank you.
Great.
Well, you're welcome. Hopefully the links will be useful.
Sure they will.
I have a question. I don't know if you can hear me
Yep.
with my earbuds. I work mainly in acute care, but I am just wondering, somebody that works kind of more in acute care setting with oncology patients, if we wanted to specialize, do you think that, I would need to get experience kind of an outpatient setting as well, or as far as like kind of with what I need to know for the board and getting, the experience, I guess, what would you recommend for that?
Well, certainly broader experience will help if your only experience is acute care, because the breadth of the exam covers all settings across the lifespan, right? So you're going to have to do a little extra work in pediatrics for sure. But just to not scare the crap out of everybody, only 5% of the exam is covering pediatrics. But that's 5% that can make or break you. So that's a good example where you might not be able to get that clinical experience. So you're going to have to supplement that. So certainly it would help to have additional experience beyond acute care, but don't let that scare you away, because I do think you can supplement that, and study groups are wonderful, especially in a study group where you might have people from different practice settings.
Yeah, I would agree, Cindy. And Jessica, I'm in the acute care setting as well. That's my main area of practice, and I agree with Cindy. I think that it's a good idea to kind of maybe just find some time to mentor or shadow with some of the outpatient therapists, seeing some of the lymphedema treatments, maybe even working into some pelvic floor. And I think that's where the Michigan Oncology SIG kind of help connect some of those dots. I don't think you have to be a master in outpatient to kind of take the exam, but you have to kind of know what you need to study. And I think that's the way that you kind of know what you need to study, is to kind of see the patient population, the problems that they have. Meanwhile, being an acute care therapist, I think puts you at a little bit of an advantage, because you get to spend a lot of time understanding some of the medical complexity of oncology. And I think that's one of the things that is hard for some people who are just exclusively an outpatient to really understand, like the pancytopenia and the thrombocytopenias and the bone metastases and end of life stuff that they don't, maybe they'll understand from a book aspect of things, but not necessarily, really appreciating it, which again, as Cindy said, a lot of the exam is really is clinical decision making. And there's a couple of right answers, and you as a clinician have to think about what the rightest answer was.
I agree completely with what Chris said. And I do think actually the acute care background gives you actually an advantage on the exam relative to those kinds of safety issues, and truly understanding the severity of the illness and the complexity of the illness that you see, because you're seeing people in acute treatment.
I think the same could be said, though, in terms of knowing and using your resources. If you're part of a health system, I think that's an additional advantage, because you get to know some of your colleagues who work in the alternate setting, and do some of that shadowing that Chris has recommended. So if you're an outpatient, don't be discouraged either. There are opportunities for you, ideally in a, with one of your colleagues in the hospital setting as well. And if you are not part of a health system, especially one that maybe has a robust program or a cancer center, even, I would avail yourself of, knowing what those resources are regionally and connecting yourself with that as well for all of those purposes to help prepare you.
Good answer, Lori.
Yeah, I appreciate that feedback. Thank you.
And you're well seated in the state of Michigan, with lots of cancer centers, lots of growing programs, certainly with the individuals on this call tonight. And as Chris said, you connect with us, you're kind of a friend for life. We can help you connect with people, and the reach is far and wide. So, we all have a personal interest in, seeing this specialty area grow. So we want you guys to succeed.
And guys, just food for thought for you to think about this. You don't build cancer centers where there are not high rates of cancer in the population. And there is a reason that Michigan has 2 comprehensive cancer centers and additional cancer institutes. This is a state where you see a very high preponderance of cancer in the population.
Any other questions right now? As Cindy said, we can all be available for questions via email. Any problems with the link that I need to know of? Did anybody try it? We piloted it earlier today, but just to make sure you can get to the Google Drive.
I just got it.
Oh, I was gonna say too, I'm on my phone listening. So is there a way, like, should I do like a screenshot and then,
Well,
how does that work, I guess?
You could do that. The other suggestion I would make is that you will have the ability to pull the slides down. And actually, this slide is included in the slide deck. Well, yeah, but you can't get there. I see what you're saying. Can you put your email in the chat maybe, and I can email you this slide deck to get you started? That's, I think, a pretty easy way.
Yeah, let me just, look for the chat here. Okay.
Yeah, I think the chat's probably the easiest way, Lori.
I'll just copy it from there.
Just set my email. Thank you.
Yeah, perfect. I'm just going to save it aside for now, and I will email you later tonight.
Can you hear me now?
Yep.
I just had a question about the residency at Beaumont. So you're actually employed by Beaumont for a year?
Yes, yep, that's correct. Is that you'd be an employee of Beaumont for a year, and then most, hopefully the goal is for most residency programs that, if you want to stay on and stay a resident, or stay a employee, there's usually almost always a spot for a good resident who wants to stay on and specialize. So yeah, and if you're interested, you can certainly email me, and we can talk a little bit offline about kind of the possibilities for potentially doing that.
Okay, thank you.
Sure.
In a different life, I would do that. That sounds awesome.
Yeah, I know.
Kind of feel the same way.
That's why we have lots of different options. You have the self-study to specialization, or you have whenever I see someone who can't do, they can't just give up their lives and go to a residency, I almost always recommend the graduate certificate program or kind of the self-study, because those are kind of asynchronous ways that you can still pursue that specialization, and you can still accomplish all of those goals just without necessarily quitting your job and uprooting your life. And I was the first graduate of Oakland's graduate certificate in oncology rehab. So, and I did it while I was working full time and going through my PhD program at the same time. So I survived.
Ditto.
Yeah, that's
I
true.
wasn't the first, but I ditto that. I'm still standing.
Yes.
I would just say if you're going to go the self-study route, that you really take the time to put a study plan together,
Yeah.
and a weekly study plan at least, if not monthly, and you really stick to it.
Sorry.
No problem. But it's worth the time to put a study plan together and to think about putting together a study group.
I have a question, and maybe you went over this. I just came back. But how often did you guys study, like those who took the test? How often do you study, like per day or per week? I'm just wondering when, obviously I have a newborn, but another child, just kind of thinking about timing and all that.
I can't speak to oncology specifically, but I am board certified in geriatrics. So I really probably studied an hour or two a night. And basically what I did was I kind of took the two top textbooks and I read them cover to cover. And then I put them down and read them cover to cover again. And that was kind of really and that's usually how I tell a lot of people to, study for that is just, on the Oncology Academy, there's kind of a resource guide where you're going to kind of have to think about what your individual gaps are. What are the areas based on your clinical experience that you just haven't had a lot of exposure to, and then kind of pick some of those off of that study guide. But to build that solid foundation, if you're going to kind of go the self-study route, finding that like a good textbook like the Stubblefield text, or maybe another textbook that's coming out soon that we could potentially, and just kind of reading through those to really get that whole comprehensive thought process. I don't know if anyone else has any thoughts.
I agree, Chris. Right now, the Stubblefield book is a great resource for, I would say, everything except PT intervention. So for everything else that you need to know, Stubblefield does cover it in some detail. So it's a great place to start from a textbook perspective. And Chris actually had a screenshot of the annotated EDGE bibliography that the Academy makes available. That's a great place to start for the EDGE papers, because there are like 33 of them, along with the clinical practice guidelines. And I didn't mention the clinical practice guidelines, but the first clinical practice guidelines that had been published by the Academy relate to lymphedema. So if lymphedema is not a strong area for you, they're a great resource to go to really supplement your knowledge relative to that. And I do know the clinical practice guideline on fatigue will be coming out hopefully pretty soon.
Okay.
Katie, that Stubblefield textbook is great for post-baby workout too.
Yeah.
Ginormous.
Mm-hmm.
I know. I was very excited when I got it.
Well, stay tuned. There's something to address soon, the need that Cindy highlighted. So.
Any other questions? If not, we don't need to hold people on, especially when they're rocking babies.
Indeed. Okay, well, I'm going to stop the recording. This will be available also likely via a YouTube link, but we'll make that available on the